Recording in progress.
On the 3rd of March 2022, for this patient was carried out a radical surgical treatment. The volume of the operation includes resection of the alveolar part of the mandibular in the chin, the tissues of the bottom of the oral cavity, in the anterior part, the tip and lower surface of tongue with plastic surgery of the defect with and nasolabial flap, right and left cervical lymph node dissection, first B, second, third groups. Histology results were squamous cell carcinoma G1 of the bottom of oral cavity, 2.1 centimeters in the largest dimension, without perineural and lymphovascular invasion. Margins of resection are negative. Postoperative course of radiation treatment was conducted for this patient from the 27th of April to the 8th of June in 2022. The volume of radiation treatment included CTV60, SIB tumor bed of the bottom of the oral cavity, the tip and anterior and middle part of the tongue. CTV54, lymphonodules of neck, a second, third, fourth group from left and right sides. Methods of radiation treatment BVUB. In calculation, the radiation therapy plan for the critical structures was within tolerable doses. The patient was treated up to the total dose of radiation therapy 50 grays. The patient declined further cancer treatment. According to patient MRI results in 12 months after the treatment, there were recurrent tumor of left part of the bottom of the oral cavity. Tumor is causally attached to the lower jaw and the level of 34-36 teeth without contact destruction, 4.0 centimeters in a gray diameter. Histology results was squamous cell carcinoma. Recurrent cancer of the bottom of the oral cavity to recurrent tumor to T2 and N0, M0. Signification factors are dose radiation treatment from 20 seconds, 50 grays, interval from radiation treatment 12 months, stage recurrent T2 and 0 and 0. Patient selection 0 without organ dysfunction, RPA class 2. Multidisciplinary consensus available treatment options for this patient: surgery, brachytherapy, conformal radiation treatment. The patient refused their proposed invasive methods of treatment.
Optimal schedule of radiation is not defined, so the specialists of the University of Freiburg analyzed 48 patients, and they revealed that the trend towards improved survival with increased radiation dose, more than 50 grays, radiotherapy boost, and completion of prescribed radiotherapy course, and the cumulative radiation dose of the patient, they irradiate the median dose of 122 gray, and with boost in boost group 124 gray. And here the plan of re-irradiation of our patient. Here you see the fusion of contour of the first irradiation in green color, the contour of the boost, the contour in red color, the recurrent tumor, visualized with CT and MRI with contrast, and the CTV 54 with 1 centimeter margin, 54 gray in 30 fractions, and the dose of the boost is 66 gray in 30 fractions. The equivalent dose is 67 gray. Cumulative radiation dose is 117 gray. The duration of the treatment is 6 weeks. And here the dose distribution with volumetric modulated arc therapy and simultaneous integrated boost. And you see the high conformity and the protection of spinal cord. The cumulative dose to the spinal cord is 55 gray, to brainstem 48 gray. Mandible is attached to the target volume, so the dose is high, and therefore the risk of radionecrosis exists. Nowadays, this patient received the treatment with chemotherapy, with simultaneous chemotherapy. I don't think that this option is the only for him, but it was the decision of multiply the consensus, multiply consensus. We think that radiation of the recurrent head and neck cancer with the modern radiation technique results in promising local control and survival rates with acceptable toxicity. Thank you for your attention, and maybe you have any questions. Thank you.
So, thank you your presentation and a very interesting case from your team from St. Petersburg. So, from our team from Ho Chi Minh City and from the radiation department, have you prepared any question for St. Petersburg team? Please, Dr. Phương, and we have a Dr. Wairanot or any leader from radiation team. Phương ơi, có ai có ý kiến hoặc là câu hỏi gì không?
Yeah. Thank you. Your presentation is useful for us for radiation therapy. I have some question. The first is my opinion is the tumor is the properly large. In my opinion, we can use induction chemotherapy to reduce the tumor volume. You can spare the organ at risk. The second question, in my opinion, I think we can guess the CTV with the GTV plus 5 millimeter receive the CT rate with the dual function.
Я поняла второй вопрос. You ask why the CTV boost is without margin. I think that we try to reach the most possible dose. That's why we reduce we don't give the margin for the CTV boost. It was our decision. I don't understand the first. Первый вопрос Анастасия не поняли?
Yes, just can we please ask doctor to repeat the first question as well? Can you help us with it because we couldn't hear it well? Thank you.
Tiếng Nga nói thẳng luôn đi. Cái câu hỏi thứ nhất.
Giảm tại con sau nói gì trước nó dẫn đầu in nó còn dẫn đầu nói chị chưa đúng không?
Его вопрос это почему вы так не принимаете химиотерапию сначала и потом радиотерапию?
We think that the simultaneous irradiation and chemotherapy is the most effective type of treatment, and so we don't suggest the последовательные. That's why we choose the most effective treatment, I think, chemotherapy and at the same time the irradiation. Any more questions?
So, any questions from our teams? Do we have other doctors from the elders who could want to raise the question for the presentation and also for the case? Do we have any more questions? Or not? So we start our presentation from Dr. Food from Ho Chi Minh City. Yeah, please, Dr. Food.
My name is Phương. I'm a radiation oncologist at the radiation therapy of head and neck department. Today, I'm pleased to attend this meeting. I would like to presentations about the irradiation for the local gynecological recurrent nasopharyngeal cancer. My presentation has to. My presentation has the four parts: the introduction, patient selection, re-irradiation, and clinical cases. Nasopharyngeal cancer is the ninth most common cancer in Vietnam. The more than the 6,000 new cases. The with IMC local, the failure rate is the 5% with 5% to the 15% overall. The much higher as the 15% to the 45% for the T4. Surgery cervical resection with the leomargine is a recommended treatment option in the upper patient. If only 31% of recurrent nasopharyngeal cancer had the surgical service and overall survival up to the 50%. The treatment we can balance between local control and treatment regime, morbidity and mortality. But no one side fits on treatment. For the patient selection, we have the multi-factor that can affect the efficacy and mobility of the radiation therapy. We can choose based on a performance status, comorbidity, detail of rival treatment, interval from the primary cause should not be less than 6 months. We can use the technique for re-irradiation such as IMT, SPST, proton heavy ion, and other such as chemotherapy, brachytherapy. In my department, we can deploy the own technique, exception, proton and heavy ion. What's the door and the vaccination? In the consensus, the total dose in the second course is 60 to 66 rate. 5%, it can be arranged with the 1.1 to 1.2 rate for fraction, and interfaction interval is 6 hours. The standard one daily is 1.8 to 2 rates per fraction. About the controlling, recurrent ZTV recommend with MRI with or without PET CT scan. And CTV is the CTV plus machine, the 5 millimeter with autonomic editing of the natural barrier such as air and school space. Some cases when the tumor is adjacent to reticle aren't at risk, we can the machine 0 millimeter. And BTV depend on your technique. With IGLT, we can machine about 2 or 3 millimeter. About the royalty ration, the royalty one, we should consider the door in brainstem, spinal cord, optic chiasm, and optic nut, and GTV. The second, the PTV and temporal lobe. And third is the carotid arterial. For the dose for the brainstem, we should consider the desirable criteria, the less than 70 gray. And spinal cord, we have desirable less than 58 gray. And optic chiasm less than 70 gray. The next, the MyRaise K presentation.
And now we want to discuss about two clinical cases. The first case is about a 46-year-old male who was initially diagnosed with nasopharyngeal cancer stage 1 with and pathology. It was non-keratinizing squamous cell carcinoma, and he was treated with external beam definitive IMRT with total for 66 grade divided into 30 fractions. And his last date of irradiation was on 7 February 2022. And after that, he was evaluated complete response. And a year later, he came to us with the chief complaint of dry mouth. And his comorbidity is hypertension under control. On physical examination, we found no cervical mass and no cranial nerve palsy. On ENT endoscopy, we found an exophytic mass on the superior wall of nasopharynx, and he was confirmed to have recurrent tumor by biopsy. And on contrast enhanced CT scan, we found that the tumor only confined in the nasopharynx without adjacent involvement and no regional laminar metastasis. On other further examination, such as bone scan, chest X-ray, and abdominal ultrasound are normal. So in summary, this patient was initially diagnosed with nasopharyngeal cancer for stage 1 in 2022, and 13 months later, he was diagnosed with recurrent nasopharyngeal cancer with recurrent tumor classification 1, and he was indicated with re-irradiation therapy using IMRT technique for 40 gray divided into 20 fractions, combined with brachytherapy for 16 gray divided into 4 fractions. And this is the contouring of this patient. We define the GTV by contrast enhanced CT simulation. As you can see the red line, we contour the GTV in the red line, and we add 5 millimeters more from the GTV to become the line. And we here have the IGRT the K fractions. So we add 3 millimeters more from the CTV to become the PTV in the yellow line. And after conversion of external beam irradiation, the patient we use brachytherapy with 16 gray divided into 4 fractions with 2 fractions per day. And this table is a summary of brainstem and spinal cord doses for this patient. Convert the doses in this table is converted into 2 gray equivalent dose. As you can see here, in the primary course, the brainstem received nearly 39 gray, and in the irradiation course, for the external beam irradiation plan, the brainstem received about 6.2 gray. A cumulative dose for the brainstem for both course was 51 gray, and the spinal cord was 32.4 gray. And back to the consensus Dr. Fung presented you about the desirable criteria for the cumulative dose for both cores of the brainstem should be less than 70.2 gray, and the spinal cord should be less than 58.5 gray. And in our patient, the dose is ideally. And next to the second case, it was a 38-year-old male who was diagnosed with nasopharyngeal cancer stage 4 in 2019. And he was treated with concurrent chemoradiation using IMRT technique with total dose for 70 gray divided into 33 fractions. And he was evaluated complete response also. And 3 years later, on July 2022, he came to us with the chief complaint of headache. And on physical examination, we found no cervical mass nor either cranial nerve palsy. And on the ENT endoscopy, we found an exophytic mass on the cerebral wall of nasopharynx. And we took a biopsy, and the pathology confirmed to be recurrent. On the contrast enhanced CT scan, we found that the recurrent tumor confined the nasopharynx and invaded the left paropharyngeal space and prevertebral muscle and sphenoid sinus. So this patient and now then diagnosed with recurrent nasopharyngeal cancer with recurrent tumor classification 3. In summary, this patient was diagnosed with stage 4 nasopharyngeal cancer on 2019, and over 3 years later, he on July 2022, he was diagnosed with recurrent tumor classification 3. At that time, he was indicated to re-irradiation with total dose for 60 gray. And this is the contouring of this patient. We define the GTV by MRI. As you can see, the inner red line, and we add 3 to 5 millimeters more to from GTV to become the CTV is the outer red line. And we found that the recurrent tumor invade the sphenoid sinus. So the PTV, we cover almost all the sphenoid sinus and apart and the posterior part of the nasal cavity. So this table this table is the summary of the dose received by brainstem and spinal cord of both cores of this patient, and the brainstem and the spinal cord is acceptable. That's all. Thank you for listening.
Thank you. Very interesting. Now, pharyngeal cancer area at our region, maybe we treat not more than 10 patients annually. And so it's very interesting to hear about your experience treating and re-irradiation of such tumor. Do you have вопросы? Yes, questions? Any questions? My colleagues have questions, please.
Thank you. Yes.
Hello, thank you for your presentations. I have any questions. What is the minimum time after previous treatment for repeated radiotherapy?
In your experience, when do you irradiate it?
Minimum time after previous treatment.
Yep. Yes. So, do you understand the question, Phương and your team? So, what is the optimal time? Yep.
I must say that we re-irradiate when the interval is more than 6 months. Better when the interval is 1 year and more. Do you have another experience? Anastasia, переведи, пожалуйста.
Yeah, so please wait forward. Yes, please go ahead, Phương. Các bạn có nghe được kịp câu hỏi không ạ? Cái thời gian mà chúng ta bắt đầu xạ trị lại tốt nhất là lúc nào trong cái kinh nghiệm của các bạn? Thì thông thường thì sau 6 tháng kể từ lần xạ đầu tiên, hay là mà các bạn có ý kiến gì khác không ạ?
In my department, we can re-irradiation after the 12 months. If the patient recurrent the soon, we can use the chemotherapy to delay radiation therapy.
Thank you. And do you use brachytherapy for the boost for the first line treatment together with external beam radiation for this localization or another pharyngeal cancer?
We don't use the Reiki therapy is the first line for the patient. We use the Reiki therapy such as the Mons tumor, such as recurrent in the T1.
Okay, and one small question. No. Can you say that the early reactions are more severe while re-irradiation or not? What can you say? Or maybe as the volume of radiation is rather small, the early reactions are not so severe.
Cái phản ứng của cái xạ phản ứng sớm của xạ có vấn đề gì không?
The side acute side effects is the same for the primary the radiation. Some cases the patient complain about the serotonin and the dry mouth and cirrhosis the muscle.
Thank you. Еще есть вопросы? Do you have the experience of immunotherapy together with radiotherapy for patients with recurrent tumor of head and neck cancer? Immunotherapy and radiotherapy for recurrent tumor of head and neck.
Ở bên mình có làm cái ca nào về tôi gọi là xạ miễn dịch phối hợp với miễn dịch với lại xạ trị Hâm Phương. So do we have any cases on the immunotherapy such as the ICI immuno checkpoint inhibitor in combination with radiotherapy, especially in the irradiation for the patient who recur? Or we use it first line or second line or what else?
The four guideline at this time we have the no guideline for the combined immunotherapy with the radiation therapy. The guideline recommend we have the chemotherapy, cisplatin or cetuximab with radiation therapy. In the nasopharyngeal cancer, we couldn't use the immunotherapy with radiation therapy.
Thank you. I must say that it was very interesting. And besides, I must say that you always have summer, but in our region, the summer is very small very cold. And very cold. I suggest to discuss next time in September the radiotherapy of soft tissue sarcomas. What do you think about? Анастасия, отключили звук.
Да, я тут.
Да.
Dr. Khan, what do you think about the topic for next time, soft tissue sarcomas?
In September, in the middle of September.
So you think that we just mentioned about the radiation therapy or in combination with chemotherapy about adjuvant or which type of sarcoma?
Whether you like, we can also ask our chemotherapists as well as surgeons to come and also to share their experience as well. It can be the multidisciplinary team, if you mind.
Yes, but actually it's a very big subject. You know that, and also what do you think about the sites of sarcoma also affect on how we choose the therapies as well. So I think that if we combine radiation, chemo, and also for the surgery, it's okay. But actually, do you think that we just narrow down the topic? For example, some type of soft tissue sarcoma or any specific sites like the trunk or the extremity sarcoma or the abdominal sarcoma, because we have so many topics that we could carry on about the sarcoma.
Sarcoma of extremities and retroperitoneal sarcomas. Анастасия, он что сказал?
Ну, он не против, чтобы мы обсуждали не только с вами, еще пригласили химиотерапевтов и хирургов, но он просит сделать тему более узкой. Может быть, какой-то подтип саркомы или там какой-то...
Maybe retroperitoneal sarcomas, as it is the most, a lot of problems with the radiation and treatment of this kind of tumors. Let it be retroperitoneal sarcomas.
Yeah, so we could mention on the we could give emphasis on the radiation for the sarcoma. Yes. Okay. Yes. So we also invite our disciplinary team, because you know that the sarcoma is very important when we have the right diagnosis on this. So we sometimes we need for the pathologies, and sometimes we need for the chemotherapy, because we all know that it is the histology directed chemotherapy for the sarcomas, and that is very different from type to type. So I understand your situation, and I agree that the next time could be the sarcoma subject, but all just for the trunk or extremity, which we can see what we can give the patient the radiation pre-operative or post-operative. We can discuss something on the subject themselves. And we will not focus on, for example, for the chemo, for example, for the pathologies, for example, for example, sometimes the reconstruction and rehabilitation for the patient. Not on that, but just the radiation for the sarcoma, right?
Okay.
Анастасия, мы, наверное, совсем согласны, да?
Yeah, please, Anastasia, please translate for me.
Yes, please. That's fine for us as well. We also can invite the pathologist just to show also our experience in diagnostic of such kind of sarcomas. But still, if you like the most, as to say,
yeah, we emphasis on the radiation.
Yes.
Just the radiation, but yeah.
Татьяна Михайловна, просто говорит о том, что очень важно пригласить и в том числе химиотерапевтов и патологов, потому что в этом можно ставить диагноз, но будем все равно фокусироваться на лучевой терапии саркомы.
Yes, and we have a very interesting clinical case for demonstration, and I think that it will be very interesting. Thank you.
Yeah.
And it will be in September, at the middle of September, okay?
Yeah, September. You want to have a 2-month break because it is July.
Or
so
maybe,
the next time is,
or maybe August or September. What do you
yeah,
prefer?
it's possible on August or September. Whatever you want, we could arrange for that. So we will discuss later, right?
Yes. The dates we will discuss just in the work in progress. Okay.
Yes. So once again, thank you for the cases from both team, from San Bernardino and also from Ho Chi Minh Oncology Hospital team. Thank you for your cooperation. Together we could go forward for some time, and I hope that the San Bernardino team could be well in this period of time, and I hope that the war will end soon. In order for both teams could exchange the team members to each other, institution or hospital, to learn directly from each other. So once again, thank you for today's meeting. And do you have any comments? The last word?
Yes, thank you very much, Dr. Bhan. And on behalf of our director, we are glad and honored to cooperate with you. And thank you for all the team to come all the time for us and to have your time for these discussions. We hope it is really not only useful but interesting for all the doctors, and we do hope that our cooperation will just only be more strong and more achievable for both of the sides. Thank you very much for your time,
thank you.
for your experience.
Once again, yeah. Goodbye.
Thank you. Wish you a not very hot letter, and for us, not very cold letter. Bye bye.
Yeah. Goodbye.
Yeah. Так, подождите, не уходите, подождите секунду. Нам отключиться-то где у нас, товарищ наш? Не вышло в большом плане. Нет, так, чтобы нас тоже не было видно.
Recording